Thank you all once again for your patience, for joining us. Very, very excited. I am Dora Muhammad, Congregation Engagement Director here at Virginia Interfaith Center for Public Policy, but I also wear the enormous hat of being a Health Equity Program Manager, which I enjoy so very much. This is our second talk in a three-part series for our JAB initiative, which focuses on three primary principles of ethics in healthcare: justice, autonomy, and beneficence, the JAB and the JAB initiative. So we developed this initiative, just a little background, to create a vital injection into the public discourse during and beyond the COVID pandemic. I believe that there's a basic understanding in language of ethics that can, in one way, a very powerful way, a very transformative way, help heal wounds of historical harm towards communities of color by the medical field. And also, the JAB initiative was developed to kind of dispel some of the misinformation that collectively prevails as barriers to care for Black and Brown people. So today we're talking about the second principle in the initiative, autonomy. And with me today, I'm so very, very honored to be joined, and you'll be hearing from them a little bit later on in the program, but want to introduce them now. I have with me the chair of the Health Equity Committee for the National Council of Negro Women, Sharah Denton. That committee is about 81 members. I was told 80 women and one man, very brave man. So, and it's just amazing work that's being done. At the size and the enormity of it. So I'm very, very excited that she has joined us today. And then also we have Dr. Mariko Nakano, who's assistant professor of bioethics at the University of Alabama in Birmingham. And so part of her training and teaching is on bioethics, clearly, but I found it interesting when researching her work and some of her writings that she is part of a team, a working group at the university. All research institutions set sort of, their research guidelines. And so she was focused on, one of the tasks in her team is focused on improving the protocols for informed consent. So I was just reading about that and really fascinated about that. And so she'll be talking about their process for research. And very, very excited to talk and just really connect and thread both of the work of these two powerful women. Unfortunately, but maybe fortunately, so I had hoped today, we had confirmed Miss Veronica Robinson, who is the great-granddaughter of Mrs. Henrietta Lacks. And so she is a practicing medical professional. And so she was working today, but instead we pre-recorded a conversation. And even though technically it would have been like 10 minutes of the program, our sit down, our one-on-one was about 40 minutes. But she has an amazing team. When we prepped, they had created a slide deck from the notes from the prep. And so that link will be available after today. Just didn't have it in time to share with you all this morning. But I'm very, very excited about all the gems that came up in our conversation, as well as sort of her work. She is a patient's rights advocate. She has done a TED Talk, which I'll mention a little bit about later. But collectively, the Henrietta Lacks family has been really sort of taken on reclaiming their matriarch's legacy. I think in a lot of the discourse that comes up in before and definitely during COVID, people point to the harm that was done to Mrs. Henrietta Lacks in sort of not getting her consent for the use of her cells. For decades, her family didn't know. And so I want to talk about that a little bit. I have, instead of that segment, because I don't have their video, which again, you all are going to love when you see it. She has an amazing, amazing team. And the slide deck was so extraordinary. And so I did pull some other videos that really short that I sort of give as an intro, and then we'll hear from our two women joining us today. And so just real briefly, wanted to talk about autonomy before I go into the short videos on Mrs. Henrietta Lacks and why her story is so powerful and pivotal in this discussion. So primarily people understand autonomy. I'm gonna just spotlight me a little bit so it'll be easier for me to move through. Primarily when people know and discuss autonomy, they know it as a person's right to make their own choices. And that's really the framework that people have within healthcare. I think throughout COVID, it definitely has raised the understanding and people's awareness of what informed consent means. which those procedures have to be a part of sort of empowering patients with autonomy. And so, but beyond that, beyond just sort of signing the piece of paper and saying, yes, we've got a patient's approval for this, and beyond sort of the traditional, let's have the patient's voice in making the decision, there's other sort of principles involved that I just want to highlight that we will create resources around, that even what we discussed today will delve a little bit deeper. But it is the idea that, and the concept that a provider, a healthcare provider, must be very, very intentional about providing education, not just sort of the options that's available, but understanding the impact of the different options. And also as a way to sort of protect against the paternalism that's existed in healthcare settings for Black and Brown people, sort of this authoritarian, we know best as doctors, you just do what we say, really, really fostering a conversation around developing a healthcare plan that respects both the values and the views of patients. And so, and Dr. Nakano is going to go into that a lot when she talks about their work and in their research and sort of how do they recruit participants, which really is the last point I want to drill down on. And it is the principle of autonomy is really there as well to protect from the non-voluntary participation in research that has so marred history when it comes to Black and Brown people connecting with the medical community. And so it comes to sort of that fear and the lack of trust because of the harm that's done from the non-voluntary part of research. And so that is really where the story of Mrs. Henrietta Lacks is really hinged on in presenting the historic lens for the purpose of today's conversation and the impact of today's conversation. So Mrs. Henrietta Lacks, and I also found a couple of videos so that I don't have to do all the talking as well. So bear with me with that. But this one thing I will share. So Mrs. Veronica Robinson, she had shared in I believe it was 2018, a TEDx talk that she did, how her family, there was sort of like this mythology of, you know, the don't walk past Johns Hopkins University or hospital with their property at night because they'll snatch you up and begin experimenting on you, you know. And so she grew up with that because of her great grandmother's history. And as I can say this, as a Black woman, I had to have had sort of those kind of mythological kind of fears from the older generations because of what was done to them. And so we center the conversation in that space to create the historic lens. And so with that, I'm going to share 2 short videos. So the first one, and then the second one is a little bit lengthy, it's about 6 minutes, by John Hopkins. So the first one, for those who do not know, there was a book done on Mrs. Henrietta Lacks by Rebecca Clute, and it's called The Immortal Life of Henrietta Lacks. And then that was done, turned into a documentary by HBO. So I found these 2 short videos, one that talks about the power of the HeLa research. And so Mrs. Henrietta Lacks, some of the videos will go into her history. She actually was from Virginia, so I love that connection. But then she moved, once she got married, she moved to Baltimore, which is where Johns Hopkins Hospital is located. And she developed cervical cancer, and during her treatment and removal of tissue for biopsy in her care, that tissue was then shipped off and sent to a neighboring facility, a research facility. And so the remarkable power of her cells is that typically, up until that time and now, human cells don't last beyond a week. Well, her cells kept living beyond, and they live the way they are, the way that her genome is, it lives technically forever, is really the term is. So today, they are still alive. Cells that was taken from her body in 1951, y'all, are still alive today. And so the short video goes into the impact of that in medical research and what that actually means, so people kind of get a sense of that. And then following that is another video on the HBO that talks about her family and sort of the making of the documentary and the power of her family. And again, I cannot wait for you to hear from her family. In the video, they do interview some of her family. And again, I had a wonderful discussion with her great-granddaughter. But the power of the family to really reclaim their grandmother's narrative amidst decades of being abused and overlooked and minimized by the health community is very, very powerful. And so give me a moment and I will share my screen and hopefully it will work. Sometimes it was working this morning and sometimes it wasn't. So
I want to learn everything I can about my mama's cells.
They've been at the forefront of basically every major medical breakthrough.
Even though Henrietta Lacks passed away in 1951, she still made huge contributions to the medical field.
Those cells were being used to help cure polio and cancer and HIV.
To know that a part of your family is the reason why we have vaccinations and in vitro fertilization is just amazing.
Everyone's saying Henrietta Lacks donated themselves. They took them and didn't ask.
Her family was not informed. Doctors had taken a sample of her tissue, and over time, what had happened to her and her cells were revealed.
Everybody come around, make money off our mama cells, but I don't care nothing about that. What I care about is knowing about my mother.
My sister-in-law, Dora Lacks, wanted to know about her mom. Her family just didn't talk about it.
You don't believe in telling stories on the dead.
My mother was so determined to let the world know who her mom was.
Dale wanted the truth. She was the only one in the family really trying to get this thing off the ground.
I want to write a book about your mother.
Dora just took it on herself to actually go with Rebecca to do this research about her mother.
Deborah was one of my greatest inspirations. I just never met anyone who wanted so badly to learn something.
Go HeLa, go HeLa. That's my mother.
I'm proud in real life. I'm proud that she's my mother and people get to know who she is.
Keeping Henrietta's story alive is something we want to do, it's something we embrace.
This woman has done so much in her death. I just can't believe this is my story.
If it wasn't for Deborah wanting to know so much about her mom, this would not have happened.
Had she not had the conviction to stay with the story, we still wouldn't know about it. The world would not have known about Henrietta Lacks. You famous, just nobody knows it.
It's very interesting because Deborah's brothers and sisters, through the course of their lives, their mother's story was revealed to them. And you see younger Laxes who've grown up knowing who Henrietta Lacks was because of this book, hopefully because of this film.
I think it's great because our family legacy is going to live on.
The younger generation has just come together on this story in ways Deborah always hoped that they would.
If she was here today, she would be very proud.
wonderful, wonderful. So before I go to the third and last video, before tossing it to our guest with us, I'm just beaming because, again, the family is so profoundly united around their narrative and the power of truly being intentional pioneers in this space to have the conversations that's needed. And so I'm going to drop a link in the chat when I need to open it, but the website, so they recently celebrated the centennial for her birthday. So it's a whole host of work that they're doing, not just here in the United States, but around the world. HeLa100.org. visit it. There's lots of resources there. They have a wonderful family tribute that they did in the various places, and sort of like a family video, home video shot. And so you get to see the faces and hear the voices of her legacy. And again, just very, very powerful in terms of saying we're not going to run away from public health. We're not going to run away from health care. Several of her great granddaughters are involved in public care as their profession. And so they lead in this space and their voices. And so I think that's so very important because, again, part of this initiative is to really focus on how do we create better relationships within healthcare settings. And so that's why I wanted to show this last video. It was created by Johns Hopkins. And so it really delves into why an important part of our initiative is to make sure that we hear from the medical community and the response, because sometimes we can stay in the past and the pain and the trauma of the past to help prevent us from being involved today in things. And so it's important for us to learn what these institutions that have caused harm, what have they done? How have they acknowledged it? How they're part of creating solutions for today. Very, very important. And again, looking forward, you'll hear directly from a member of the healthcare community. And so this last video I'm going to share is about the legacy and what happens right today at Johns Hopkins University. So my last share.
At the center of the Henrietta Lacks story are people asking questions. For people trying to understand the biology of human cells, it's there for bioethicists, for patients. This is why Johns Hopkins is committed to outreach and education for all the community.
It's a labor of love. We all feel like we're connected to this beautiful woman who we call the mother of medicine. It really makes you think about how powerful an impact one person unknowingly could make.
Good morning, everyone. Thank you all for coming to learn more about my great-grandmother and what her legacy has left for all of us here today. So over 60 years ago,
in my capacity as the director of outreach for the Institute for Clinical and Translational Research, I organize educational programs related to Henrietta Lacks. And the main focus is to increase awareness of Henrietta Lacks's impact on medicine and society, to gain a better understanding of the science behind HeLa cells, and also to create an open dialogue about the social issues that were occurring around the time in which Henrietta Lacks's cells were cultured.
I would say that Henrietta is probably, if not the most important, certainly one of the most important women in science and medicine. And we all learn and follow Henrietta Lacks' legacy as we contribute to research and medicine.
Henrietta Lacks was a 31-year-old woman admitted to Johns Hopkins in 1951 for the diagnosis and treatment of cervical cancer. Unfortunately, she had a very aggressive cancer, and within a year, she had died. As part of the care she received at Johns Hopkins, the cells from her cervix were brought into a laboratory and cultured and have become the first human living cell line, which has allowed us to learn remarkable things about how human cells function.
That was really, in my opinion, the launch pad, probably the greatest discovery in biomedical research in the last half of the 20th century. It has led to numerous discoveries and development of technologies.
It provided the ability for us to understand how cells grow, how cells divide, whether cells can survive in extreme climates, going into outer space, how radiation damages cells, how we can produce lots of material to make things like vaccines, which is all part of what the HeLa cell has done for science and for the public.
Just the fact that, 65 years later, a sample of our grandmother's cells still exists out in the world today is almost superhuman.
Our responsibility is to honor the legacy of Henrietta, to thank her family and thank her posthumously each year, which is what we do. We have a Henrietta Lacks memorial lecture. I think last year we had 1,000 people attend. Each year we organize the Henrietta Lacks High School Symposium. We've partnered with the Henrietta Lacks Legacy Group, the Turner Station Conservation Teams, and other groups to form a book club that builds a bridge for people who live in this community and Hopkins researchers to get together and really talk about issues. We also have the Microscope Day, in which we open up the laboratory of one of our colleagues, Jim Potter. They learn about the significance of her cells. The Johns Hopkins Urban Health Institute offers a $15,000 partnership grant to community-based organizations that partner with Johns Hopkins researchers to address health challenges that are impacting people who live in Baltimore. We also partner with Dunbar High School to offer the Henrietta Lacks Scholarship for individuals who are interested in pursuing careers in medicine. And that is really, to us, one of the ultimate ways of honoring Henrietta Lacks, is to increase the prevalence of individuals working in medicine who understand the unique challenges of the community.
This scholarship is way more than just academics. Is me being a part of a legacy. It shows you that Henrietta Lacks herself did more than help cure diseases. Her sacrifice has given teenagers like me an opportunity to excel in their future.
Students are the next generation. They're the next generation of doctors, researchers, scientists. So to get them exposed to the story of Henrietta Lacks and see the mistakes that were made and how we are moving forward, possibilities are endless.
What was most interesting to me was what the providers were saying.
Collaboration between the community and academics is what medicine is supposed to be. We're not supposed to be an ivory tower. We are supposed to be working with the people we serve. And by reaching out to the community, we better understand them, their needs, and they understand what it takes for us.
At some point in some time in life, everybody's gonna get sick. Everybody's gonna suffer from some type of disease, some type of cancer, some type of dementia, any type of thing. So we need research to, find cures, find medication, and find some kind of prevention. So I think it's very important research, and I think, we need to do our part to get involved.
So again, I want to say thank you for helping us honor my great-grandmother, Henrietta Lacks, and what
Henrietta passed away, but yet she still lives on, and she's making a huge impact on society today.
Wonderful. I just feel like we need to just give a hand clap to the family and their legacy. But thank you. So right now, I'm going to pass it on to Sharah Denton. So I'm going to add her spotlight in. There she is.
Good morning. I'm Sharah Denton. I am the Health Equity Chair for the National Council of Negro Women. And in September of 2020, Dr. Janetta Besh-Cole, our National Chair and President, appointed me as the Health Equity Chair for one reason in particular. One reason is that there's so many health disparities that hurt our communities, our Black and Brown communities. And we had to streamline and focus on 6 areas of top concern and then spread out beyond that once we were established with the foundation. One thing that we found was that there was so many health disparities and so much lack of factual information being presented to the communities that we were serving. And one area of interest was vaccinations. I heard in the video where they were talking about earlier in the conversation, we're talking about the distrust of our communities. And that was one thing that we noticed across the board when it came to health equity, that a lot of the health disparities that affect our communities, we're not doing what we have to do to be fully educated on it. And a lot of us don't even have the resources to further engage in receiving resources and valuable information as it pertains to health equity. That fear, I have learned from this committee, is one that comes from a broad strand of individuals, both professionally and economically. There are people in the health field that are minorities that sometimes are a little uneasy about some of those target areas for health equity and establishing truthful information. A great example is when the pandemic started. I work for public health, that's my day job. And one thing that we noticed was that a lot of people within public health on the state level were working in fear. And once you work in fear and you put that out, information out, and it's not necessarily all the way accurate, that creates a larger impact on the fear that's historically embedded in our communities. So one thing that the National Council of Negro Women wanted to do, the first thing was to provide education. We want to educate our members and their families and our communities on factual, valuable information. So we did a span across the United States within NCNW to find members that were in the medical fields, that were experts in their fields, to discuss health disparities, challenges, and debunk a lot of myths that are out there. On top of that, we also have what we call leads. Now, these leads are people in different fields that are related to our target areas in health equity that can provide that factual information. People that are in the field that know facts, they know resources that are available, and they're able to provide that information to our members and those that we serve. As stated before, we have over 80 members in this committee, one male and the rest are women. I have all due respect for him. I don't know how he does it with all of us, but he's still holding on a year later. But he brings on a different perspective as far as from a male and minority standpoint, because when you talk about health disparities, there's a big gap in our male population as well with receiving medical care and resources also. But with this committee, it was very important that we provided a committee that was filled with experts that can help us debunk a lot of myths and misconstrued information. One thing that goes against us, I think all of us can agree, is the beauty of social media, where people can put things out on social media and people run with it. It doesn't necessarily mean that it's true, but it happens a lot. And we found that a lot with one of our partnerships that we do with Good Health Wins that's focused on vaccines and vaccinations in the minority communities, where a lot of people feel like if they're pregnant that they cannot take a vaccine because, or if they don't have children, that it will prevent them from being pregnant down the road. So we are doing everything that we can to provide factual information and initiatives. We've had town halls, we've had webinars to debunk a lot of these misconceptions about different levels of health equity. And speaking about Henrietta Lacks, which as an African-American woman is very powerful to hear the story about her. Every time I hear it, I just kind of get empowered, because if her daughter did not do what she did and really push the issue, we would be living in a world of a lot of disparity. I think it's very phenomenal as African-American women and brown women that we do now understand our voice. And so one thing we want to be able to do is provide that voice so that we can provide support. And with that, there is still a fear of, if that's happened to Henrietta Lacks, how many other times has it happened? Of our people being used in that way. That's something that NCNW also focuses on as far as making women and members understand that they have a voice, and that what you have the right to ask questions. You have the right to provide the information that you want to provide, but it's not right for you to be used in that way and then not receive any type of recognition for that. And I'm not saying recognition as far as, the glitz and glamour, but with Henrietta Lacks' family is a prime example of how much our communities provide to science, and we might not know about it. And so with the National Council of Negro Women, we are advocating for facts and going against the grain to find out information, to push out the objectives of health equity and facts and resources, and giving everyone a voice. Because Henrietta Lacks, the fact that her name is still brought up to this day, and that was before I was even born or thought of. So that tells you how powerful something as her situation is even now, and how monumental it is for us to be educated in what she has contributed to science and to the world. Another thing I did want to address is, how do we overcome this fear? And I think I mentioned this before on another event I was at, we have to have those hard, difficult conversations. We have to face the fact that there's a lot of disparities in our communities, and we have to not be afraid to talk about it and to ask those questions. Because just like with Henrietta Lacks' daughter, had she not asked the questions and kept asking and kept pushing, there would be so many things that would be affected by that. And so I think we have to have those conversations from an advocacy standpoint of not worrying about that part, but just getting down to the bottom of what it is that we need to find out and be on top of when it comes to health disparities that especially affects our communities. Historically, you'll see a pattern of African-American and brown people being used as not humans. They're treated as if they don't have value, or they don't have, they're not human. And I feel like with Henrietta Lacks and other stories similar to hers, it's kind of the same thing, where we're not respecting them as individuals. We're just using something that we can take from them. And we're not really monetizing on the fact that this woman provides not only to science, but she's the reason why we have so many powerful advances in the medical field. And I'm not coming from a clinical standpoint. I don't want to say anything like I'm a doctor, I'm not. But just from the advocacy standpoint, a lot of things that we do not know, because people are scared to talk about it. They don't understand, or they just go with what they hear. And I think it's honorable that her daughter pushed the issue the way she did, because now we have a lot of solutions to those health disparities that we've talked about so far. I'm sorry, Virginia. I didn't want to keep going if I had to.
You don't even have to. Yes, I'll join you so we can chat a bit, because I did get one question for you from someone who emailed it to me. And they wanted to know sort of, how do you all as a committee work to really galvanize unity among the members as you're forming the educational pieces to really be and remain a trusted voice when there's so many other voices out there around what people were trying to get educated on?
Well, one thing that's very important within the committee is collaboration. So although we have a diverse group of people across the US, different ages, different experiences, one thing I do love about this committee is that we're able to come up with a consensus and kind of see it from different spectrums versus just one pinpointed, like how we're doing now. I can come from the advocacy standpoint, but someone else on the committee can come from a clinical standpoint, and then find that happy medium to where it relates to the people that we're trying to give this information to. And just like with the male on the committee, he provides a certain aspect that 80 of us on the committee may not understand. But then we kind of find that common ground with one another where we discuss that and we work through that. And it's always a pleasant consensus, because it's like, okay, I never thought of it that way. So then we all provide that type of feedback to where we kind of see each other's different perspectives in a way that's relatable and factual at the same time. If you're in a clinical standpoint, you might see something very scientifically, whereas me, I'm seeing it more on the outreach level. So we kind of find that balance. And not to say we don't have our challenges sometimes, but I do feel like because we have so many different personalities and backgrounds, it actually works really well together.
Nice, very nice. Well, thank you. Thank you. I want to bring Mariko on in a second. And so one interesting fact, which will bridge this really nicely. So Dr. Dorothy Height, founder of NCNW, she was a part of, as Sharah was talking about, sort of the empowering women's voices and sort of being a part of that today. So the history and the legacy of NCNW to this conversation. The founder of NCNW in 1978 was a part of the first national commission. And I'm gonna have to read this because the name is long, but there was a commission that was established federally to work on ethical principles within research and guidelines. So I'm gonna read the name so you'll actually have it. I can't remember it. It's the National Commission for the Protection of Human Subjects of Biomedical and Behavioral Research. And they produced what was called the Belmont Report that was linked to where the conference was actually held. And so that report really established the first guidelines for research for human subjects. And so I just wanted to put that shout out there for our history. Again, just it's important, as Sharah was mentioning and talking about the clinical voice. With us today is Dr. Nakano. And so I'll turn it over to you to offer sort of the clinical perspective in response to in the work that you all are doing. Thank you for joining us this morning.
Thank you. Thank you, Dora. And thank you all for inviting me for this important conversation on autonomy. So I'm Mariko Nakano, Assistant Professor of Bioethics at the University of Alabama at Birmingham, here Singh School of Medicine. And I'm very excited to be here. So let me talk about the healthcare research project we are doing here in the state of Alabama. And let me explain how we strive to respect the informed autonomy of our participants. Our healthcare research project is called the Alabama Genomic Health Initiative, or AGHI for short. And this is a statewide genotyping and genome screening project, which started in 2017. Now, genotyping is a method used by researchers to look at the pieces of DNA that are known to cause certain diseases and responses to medications. So the AGHI intends to offer genotyping to volunteering Alabama residents. And the goal is to recruit a total of 10,000 volunteers over the course of 5 to 6 years. And as of now, over 6,400 people have joined the study. And it's funded by the state of Alabama, and it's a joint project between UAB and Hudson Alpha Institute for Biotechnology in Huntsville, Alabama. And principal investigators, Dr. Bruce Korf at UAB and Dr. Greg Barsh at Hudson Alpha. And I'm serving as co-chair of its bioethics working group with Dr. Tom May from Hudson Alpha and Dr. Stephen Shodeke from Tuskegee University's National Bioethics Institute. And the AGHI is a half clinical, half research project. As a clinical project, the AGHI aims to prevent and treat what we would call medically actionable gene-related health conditions, such as certain types of cancers, heart problems, high cholesterol tendencies, and a certain type of reaction to medications used during general anesthesia. So we provide genetic testing, interpretation, and counseling free of charge to volunteering residents in each of Alabama's 67 counties. So we recruit people from all racial, ethnic, and socioeconomic backgrounds. So, but our scientific knowledge about the relationship between genes and diseases is still limited, and we need to do research studies to learn more about our genes and our health conditions. So as a research project, the AGHI asks the same volunteers permission to have their remaining blood samples and their basic health information stored in a research storage called a biobank and database, so that researchers can further analyze them to advance our scientific knowledge about genes and diseases. And we do this research in order to find better cures and preventative measures for a number of diseases that are currently affecting us and are going to affect generations to come. So through this Genomic Health Initiative, we want to promote the health of Alabama residents as well as future generations in and out of the state of Alabama by offering what we currently know about health and genetics and by finding better treatments through research. And in this regard, we view participants not as subjects who are just experimented on, but as partners with whom we strive for better medicine together. And we believe informed autonomy is key to healthy partnership. And when we say participants as partners, we do not mean a business partnership or transactional partnership. As far as our genomic initiative is concerned, it's unlikely that the findings gained through our research will generate measurable monetary benefits, because what we will get is new knowledge about health and genes, not any products or special cell lines we can sell. But we do believe that the genomic research on the AGHI samples will lead to new knowledge about better ways to treat or prevent certain health conditions. So improving people's health is our goal, and we see participants as partners in attaining this health-focused goal. And anyway, as I said, we believe informed autonomy is key to healthy partnership. But from the beginning of our initiative, we were aware of one obstacle to informed autonomy, which is people's mistrust in science and research. So if you remember Mrs. Henrietta Lacks' story and the notorious PHS syphilis study in Tuskegee, Alabama, there's no wonder there are still people who don't trust scientists. So we thought we should make our very best effort to mitigate mistrust and build a trustworthy relationship with the participants who should be our research partners. So let me talk about the role of IRB, Institutional Review Board, in promoting autonomy at this point. As a response to a series of infamous research studies in the 30s to early 70s, all research that involve human subjects must be reviewed and approved by the IRB, the Institutional Review Board, prior to the initiation of the research. So today, every research institution that receives federal funding has its own IRB, which is made up of at least 5 members, including both scientists and non-scientists, and at least one community representative not affiliated with the institution. And before a research project can be initiated, researchers must submit fully detailed research plan to the IRB and get an approval. And the research plan submitted to the IRB must include an informed consent form that will be actually used in the study. And IRB review is an important safeguard against a reckless research study like the ones done in the past. But we don't believe IRB is sufficient to achieve participants' informed autonomy. This is for two reasons. For one thing, our IRB requires that the informed consent form must include certain definitive sections, and it must use some fixed languages here and there. And as a result, the official informed consent form tends to be very long. Ours is actually 13 pages long, and it may be rather difficult for laypersons to read and fully digest what's written on them. And second, just submitting paperwork to the IRB does not necessarily involve active interactions with people in the community. So we need to learn from our future partners and know their needs, wishes, and values before working together. So in the AGHI, we devised multiple ways to better respect patients' informed autonomy and strengthen our partnership. I'll explain 4 of our efforts. 1, we sought advice from Community Advisory Board and Community Discussion Group. And 2, we used patient navigators to assist participants' decisions. And 3, whatever choices made, we honor and follow our participants' decision. And 4, we set 4 core values that should underlie our initiative. And let me explain a little bit more. And first, we established and interacted with the Community Advisory Board and targeted discussion groups to learn about what our community expects from our genomic health initiative. The AGHI Community Advisory Board was created early in the study in summer 2017, and there have been constantly around 15 board members who are representatives from the community and clinicians and health system executives across the state of Alabama. So, and they advise on particular recruitment strategies and how to improve visibility, understanding, and support of the AGHI throughout the state. And in year 3 of the project, efforts focused on how to increase enrollment of African-American participants in order to mirror the current Alabama demographics by race. And advisory board members provided broad recommendations as well as context to facilitate AGHA engagement with faith-based organizations and outreach at community health fairs. And in addition to the Community Advisory Board, we also held facilitated deliberative group meetings by inviting stakeholders in education and public opinion. And we asked them to discuss questions such as, what genotyping results would you and others in your community want to receive? For example, would you want to know your risks of developing incurable diseases, or would you like to receive medically actionable results only? And at the end of the discussion, the members of this discussion group voted on the action items about what the AGHI should do. And we listened to that. And second, we employed patient navigators, who digest our messages and help assist participants by going through the entire informed consent process step by step with each participant. And all navigators and site coordinators received a bioethics training to understand the historical background of mistrust in the state of Alabama and reasons why trust issues are critical for our project, and the reasons why we should be transparent, honest, and respect participants' autonomy. And third, we emphasize respecting the choices made by potential participants. And during the informed consent process, patient navigators will answer any questions from potential participants, and potential participants can choose whether or not to participate in the initiative absolutely without any penalty or other negative consequences. And in addition, on the consent form, participants can choose whether or not they want to have their blood sample stored in the biobank and used for future research. So you can consent to have your blood tested, but decline to have your blood sample stored for future research use. And as of now, about 92% of all participants have consented to biobank according to the data we have. And fourth and last, the AGHI Bioethics Working Group has proposed 4 basic values that should be held throughout the research project. These are transparency, such as honesty, respect, confidentiality, and fairness. By transparency and honesty, we mean we should be honest about research benefits and risks, and we should not deceive or mislead participants. By respect, we mean to honor our patient's choice to participate or not to participate, and to avoid exploitation or stigmatization. By confidentiality, we mean we should keep sensitive personal information confidential. We strive to maintain participant confidentiality, not to hide research findings from participants, but to protect participants from adverse effects resulting from identity disclosure, like gene-based discriminations in employment or insurance and others. And by fairness, we mean we should reach out to diverse population, and we should not exclude or exploit any specific group of people. And we believe that these will be a sound basis of ethical operationalizing of our research study, and we hope that our efforts will lead to better assist participants' informed autonomy. Now, participants may also want to know how they contributed to science after any research is done on their donated samples. And by the principle of transparency, we researchers should have the obligation to make our research findings transparent to the eyes of participants and the general public. And the AGHI does and will make our best efforts to disseminate any useful information gained through the initiative by announcing any progress and any scientific findings, not only through academic journals, but also through public media and annual reports, even though we cannot recontact each individual participant to let them know of how their sample individually contributed to a particular finding. We cannot reach out to individual participants partly because scientists who work on the AGHI stored blood samples cannot identify each sample. This is because the stored blood samples are stripped off of all identifying personal information, such as participants' names, date of birth, addresses, and so on and so forth. And each sample is labeled with a unique identification code instead of participant names or medical record number. And also, as far as the AGHI research is concerned, it's unlikely that one single blood sample will make a distinct contribution to a medical breakthrough. So the research being done on AGHI sample is aggregate analysis, meaning that a number of samples are compared with another large group of samples to find meaningful differences between the two groups. So no one sample will make a measurable contribution. But in some cases, though, participants who agree to be recontacted might be asked to participate in a different study that will go into more depth on a particular topic, and then the sample might have more direct impact. But in that case, the recontacted person will know what contribution he or she makes to the genomic science. Anyways, this type of population genomic initiative cannot generate a meaningful scientific finding without the help of a large number of volunteer participants. And respecting their informed autonomy is key to healthy research partnership in promoting genomic science. And we believe we are doing our best, but our limited perspective may not capture all possible concerns and weaknesses about the ways in which we attempt to respect participants' autonomy. So honest communication and open-minded interactions will be a key. And that's part of the reasons why I'm here, to listen to others' views and opinions and questions. So thanks for listening. My part is done, I think.
Yes, hold on. I want to keep you here though, because I wanted you, thank you for that, just peeling back the clinical perspective. And thank you for your humility in that, saying and acknowledging that it's limited. I wanted you to talk about, you mentioned it, but when we had prepped, I really want you to take a minute to go into, you had talked about how the research is to create new knowledge. And so when we had talked, you had mentioned how the phrase you used was finding better science. And I really wanted people to hear you talk about that. And especially to what some things you just mentioned, you know, the idea that you're constantly learning. And I think people don't understand that, like in terms of this constant study, this constant learning, and you closed off on that, like how you're still here to hear and listen and learn. So humble to say that, because it really goes against that sort of that trope that doctors know everything and they come into the room, and sort of it helps ease, even as a patient, hearing and knowing that I'm not being experimented on to hurt me, that this is for the benefit of future generations, I think was some of the things that you, so just take a minute to talk about that. I really want people to hear that from a clinical voice.
Okay, definitely scientists and doctors don't know everything about human body and how it functions. That's part of the reason why we want to do research on that. We have a limited knowledge about how our genes affect our health conditions. And currently there are 74 gene differences are recognized by the genetic differences, we call it genetic variants, and 74 genes are believed to be related to some increased risks of medically actionable diseases. And this is acknowledged by the American Associations of Medical Genetics and Genomics. And those include some cancer risks, like breast cancer. The genes called BRCA1, BRCA2,
Yes.
is one of the two ones that's known to be related to the increased risk of developing breast and ovarian cancer. But there are many other potential genes that can cause the same or different kinds of cancers or breast cancers, and we don't know about that. What we know about is that at least BRCA1 and BRCA2 are related to the increased risk of breast cancer, and there are other people who develop breast cancer without those kinds of genetic variants, and we need to know what are the genetic cause of these cancers and other health conditions that are affecting these individuals. So we need to know more. And in order for us to gain knowledge about that, we need to compare a group of people's different DNAs, different genetic makeups, and compare with another people who doesn't develop the breast cancer and the targeted health condition. And we have to compare these large people, two large groups of people, and compare the genetic differences. What are the critical genetic differences that this group has, so that this group will develop breast cancer, this certain type of breast cancer, and whereas because of the lack of this genetic variants, this group does not develop cancer, the same kind of cancer. So we need to recruit a large number of people and compare the differences of different people's genetic makeups and gain useful knowledge to develop. And by finding that, we can possibly develop a way to, cure or prevent those kind of health issues. So that's what we are trying to do.
Really good. And I want to footnote something before bringing Sharah in for one of the last questions that I received before today. And because you've said it several times, and it made me it's something to me I just want to highlight for people listening. When you talked about the research projects, how important it is to get a large number of people participating in it. And I say that too because there's a lot of papers out there, or God knows this whole YouTube video library of medical experts that base research on these very small studies that's done in very small groups. And so it tends to be one of the factors to really, what's the word? Not to say discredit it, but because you can't reproduce the results, or because there's different things that make research very viable and trustworthy. And one of them is having a large subset of participants, and also being able to reproduce it. I got a third one, but there's different criterions. But I just know that a lot of these is like these small, almost minuscule populations that participate in the research. So thank you for highlighting that. And then one last question I have, and everyone listening has questions, please put in the Q&A. But I did have, I'm going to bring Sharah in. There's a question for both of you. And please answer, from your perspective, professional capacity or even personal capacity. And it is the question of the state of informed consent today and in the future. Do you think that informed consent is evolving and expanding, or being eroded and encroached upon? And the person had emailed all these different examples of ways that, both are happening. So I wanted to sort of get your perspective in terms of what you're hearing and seeing, and do you feel that we're at the state of informed consent today and into the future? So Sharah, you can begin, and then Mariko, you can go.
Oh, that's a tough one.
Okay. You want a few minutes to think?
I mean, personally, I just think, I think it depends on what we're talking about, because I think sometimes we are pushing it, and I think sometimes we're not as much as we could be. It goes back to that fear or lack of understanding, or I guess in some ways control too. It just depends on what perspective we're coming from. I guess I could say that from a personal standpoint, because sometimes there's times where I'll see it really being pushed for certain things, and then there's times I'll see it kind of being brushed aside, like, let's just move past it. And I think it's a little tricky, especially when you're dealing with research, because and I'm not saying this about everybody, but just working where I work, I've seen it on both sides. I've seen it to where it's like, let's just get what we need and get past that. And then I've also seen it where, no, we have to follow every step and make sure we have the okay to do this. So I just really think it depends on which perspective you're coming from. But I've seen it both sides.
And Mariko, your perspective?
I think that as a concept, informed consent is an important concept to promote participants' autonomy, informed autonomy. But in reality, the actual informed consent form is getting longer and longer and more complicated, partly because there's a requirement from the IRB or the regulatory background, and partly because we need to provide accurate information, part of which has to be explained in scientific terms. And if we make the informed consent totally easy to understand for teenagers and younger children, it may lose accuracy. And as a result, the informed consent is getting more and more, complicated, and it's getting hard to understand. And sometimes the research coordinators, not in our study, but it could happen that the research coordinator just hands over the informed consent document and tell them this is to participate in the study, and just sign, and without reading it. So that will be against the intent of the informed consent concept. And I think what's more important is to communicate through the informed consent process. And what's important about the informed consent is to let the participants know what's going to happen to them. And the participants should understand what's being done to them and fully understand the risks and benefits and what's going to happen after the research ends. And then they give their permission. So that's the important thing. And informed consent document itself does not necessarily do that job. And that's why we think that more support can be needed. And that's part of the reason why we use more resources like the patient navigators to support the decision-making process.
And so we don't have any questions from the attendees. And so I want to close out on a thought and sort of get your feedback on it. So this isn't a question, it's just something I came across in researching and preparing this. Of course, in my day job as Health Equity Program Manager, one of the policies that I'm looking at here in Virginia is sort of cultural competency training and implicit bias. And so when I was reading about autonomy, that came up because I read and I was intrigued. So I read, and again, this isn't mainstream because again, there is, like I mentioned earlier, a traditional understanding of the principle of autonomy being sort of the individual decision-making process. And I read that there's sort of an emerging, again, when anyone who's listening, this isn't mainstream, it's just an emerging thought to sort of shift and expand or transform, if you will, the traditional understanding and framework of autonomy from being individual-based to really being relational is a term that I saw. And it was really placing it within several contexts. And so one of them that I read was the cultural context, understanding how providers need to understand that as an individual, I do make my decisions based on sort of my family harmony or my community, sort of community context and consequences. And there's certain values that we come. So the decisions sometimes decisions are made as a family unit, more so than just sort of what is going to affect me. And I definitely thought within the context of the pandemic and sort of the individual health versus public health, that came up and rose a lot, sort of that, am I making these decisions just based on what's going to affect me or society, sort of that society relationships. And it's rooted in sort of the new concepts that have been evolving and developing and strengthening and taking root in the idea that we have a shared reality. We live in a shared truth. And so we just wanted your thoughts on that. Again, it's not a full question. And so, but just wanted your thoughts on that. And one of the examples is totally not health related, but so people can understand sort of what this means by relational and community and society. One of our works here at the center is trying to preserve ancestral grave sites. And as I was talking with one of the state agencies on preservation, they were talking about how removing, like when there's development that want to kind of disturb ancestral graves, and it's like, oh, well, just move the plot to a different part of the city or whatever. And, and so she was saying how dealing with white ancestral graves, that's not a problem. But if you're dealing with Black and indigenous, native ancestral graves, there's a whole value system that when you bury someone, that life then becomes part of the earth. And so the land itself becomes sacred. So moving it is like violence, so understanding that concept and that value system is important. And so that's sort of the framework of what it's like when you make decisions from your value system as your culture in healthcare settings. So just again, wanted your thoughts on that in terms of the idea of shifting autonomy to look at the decisions that we're making from a communal relationship kind of perspective, especially dealing with public health. What are your thoughts on that? Mariko, do you want to begin?
I think that relational autonomy is an important, and the concept of shift from individual autonomy to relational autonomy is a valid, thinking. And I think that that's part of the reason why I always use the term partnership and informed autonomy. Autonomy, the self-decision making cannot be done without adequate information and communication with others who can give you the information. And I still think that self-decision making is an important aspect. You shouldn't be overly influenced against your will by the social values shared by others, but still, as far as your influence and your the community's values embedded in your own value system, you should be aware of that, and using the relational autonomy, be informed autonomy, you should be able to make your own decision. So that's how I perceive the notion of autonomy at this point.
And Sharah?
Oh, I was going to agree. I agree completely with that.
Excellent. Yeah, and I want to add this before closing out. And thank you, ladies, for joining me for this wonderful talk this morning. One of the, as you were talking, Mariko, one of the sort of the principles and elements that sort of retain sort of the individual space and moved it beyond sort of just a decision making when there's an intervention that needs to happen is really creating a patient-provider relationship where questions can be asked, where there's really an input, again, of the value system. And so I know for me, I've walked out of healthcare settings when it's like I'm being totally shut down. It's like, are you listening to me? Like, do you hear what I'm saying? Or can you answer my questions? Because you want people to be fully involved and participate in their health care, and it's not just what you're going to do to me and the risks, but also, does this align with who I am? How do I see myself and understand myself and want to be healthy in my behaviors and my concepts in the world? So I want to thank you all. I'm going to do my closing PSA, but wanted to see, before I did that, did you all have any last words that you want to share to close out? I'm going to proceed, if you all can stay, who's with us. I'm going to drop a lot of links in the chat so that people can see it when they access the recording as well. If you need to email me regarding this session or the previous talk or any questions, you can reach me at jab@virginiainterfaithcenter.org, and I will put that in the Dropbox. And I hope to see you for the last, third, and final talk in this series on December 11th. We will be focusing on the principle of beneficence. So Sharah and Mariko, any last thoughts?
Just thank you for the opportunity. I've enjoyed the discussion.
Yeah, thank you so much for this opportunity. I learned a lot.
Thank you. Thank you. Wonderful. Okay, so thank you all. Have a wonderful afternoon.
You too.
You too.